what am I going to do? I'm going to talk about clinical trial reports. Most of my examples are cardiovascular clinical trials. And can we trust the claims that appear in clinical trial reports? So I've already gone too fast. So when you see reports of a major clinical trial, they come in layers of information. Firstly, you get the company press release if it's a major trial, and when they are often prone to have a little bias in them. Then you get the conference presentation, which is not peer-reviewed and therefore may indeed also exaggerate the claims of treatment efficacy, for instance. Then you get the journal publication, which is peer-reviewed, but that doesn't contain everything. And the real totality of evidence is really in the regulatory submissions that go to the FDA and the EMA. And after that, if approved, you then get company advertising, which may leave you back where you started. To try and get assurance of quality of clinical trial reports, for the journals, we indeed have peer review. We also have guidelines, consult guidelines on what constitutes what should be in a trial report. And then for the regulators, again, I just said totality of evidence, and we have international guidelines on how trials should be reported in a regulatory context. So what leads to questioning whether a trial report is any good, really will change the world? Firstly, there's issues of internal validity. Is the trial okay in its scientific content? Was randomization done? And was it inadequately reported as to what went on? Just to say your trial is randomized doesn't mean all the randomization process was done correctly. For instance, if you randomize a patient, but you already knew in advance that which treatment it was going to be, that's not really randomizing. So allocation concealment is important. Secondly, in many drug trials, we have blinding or masking, but not all. And was that indeed implemented satisfactorily? The third issue was the trial big enough to really come up with a precise answer, and that's where statisticians coming in to determine trial size. Other issues are patient follow-up. Were there problems of dropouts, non-compliance, which dilute the ability to detect treatment differences and introduce their own biases? And then there's the results. Were the analyses correctly done? Was there an emphasis on predefined aims, and was it a clear and informative presentation? So when you come to the conclusions, amazingly, the question is, were the conclusions actually compatible with the results? And the answer is not always. Was there a balanced account of both efficacy and side effects, and were the limitations appropriately assessed? So that's internal validity. Equally important is external validity. Were the relevant patient studies? Beware of inappropriate extrapolations. For instance, if in clinical depression the trial was entirely in hospitalized patients, that doesn't really enable you to extrapolate to patients in a primary care context. Were the treatment regimens appropriate for what you'd like to see? Were they implementable, cost-effective, and was there an appropriate control group? Outcome measures. Were they really relevant to patient well-being, or were you studying surrogate markers, which you hope are relevant but may not tell you the answer? And in many therapeutic areas, was the treatment and the follow-up period long enough to really tell you about the outcome for patients in a way that really matters? You look at other evidence, adequate account of other trials, a biological rationale for what you're doing, and then we enter my world of constructive critical appraisal. Now, in my lecture, I'm going to attack various trials politely in my English accent, but recognizing that no trial is perfect, but we each need to appraise critically what's going on. Statistics in trial reports. It's key to beware of positive spin. If you're not familiar with that phrase, it means after the event, you've got the results. Do you put a post hoc emphasis on the good news and tuck away the bad news in your filing cabinet? Andrew Lang put it this way. He uses statistics as a drunken man uses a lamppost, for support rather than for illumination. What doesn't help this along is the obsession with p less than 0.05 as a marker of a positive trial, which is an unfortunate event. And with lots of data to play with, you can do what I call data dredging, looking through the results, selecting the ones you like the most as a sifting through. So let me start by giving you an example of data dredging. Cardiovascular trials have lovely names. So this one was called Beautiful. It was a trial of ivabradine in a large trial, 10,000 patients with stable coronary disease. The primary composite outcome was cardiovascular death, myocardial infarction, or heart failure, with a median follow-up of 90 months, which is not too bad. The primary endpoint results were virtually identical, ivabradine versus placebo. And once you see that, and you've invested millions in doing this trial, not just the company, but the leading cardiologists responsible for the trial are saying, that's disappointing, let's try harder. And so the harder, what do? Well, you say, well, let's concentrate on the subgroup of patients with a heart rate above 70. Well, that helps a bit. The primary endpoint result is at least now pointing in the right direction. And the p-value is 0.17. So, well, that's not enough, is it? So let's pretend we always wanted to study myocardial infarction alone in patients with a heart rate above 70, and then you get a treatment difference of 3.1 versus 4.9% of event rate, and the lovely p-value they were always dreaming about, p of 0.001. Now, I would say this result should not be denied publication, but it should be deemed hypothesis generating rather than a key emphasis, because it's not what you set out to primarily study. And the Lancet probably got better on this sort of topic, but they allowed this to be highlighted, this result highlighted in the conclusions and abstract of the trial. I think we need to be a bit more careful than that and say, look, this drug didn't seem to work in this setting. It did in heart failure, but not in this setting. So that's a cautious note of what I mean by data dredging. Now, let me give you a short history of the p-value. It's nearly 100 years old, but not yet. R.A. Fisher. He was a formal man. He didn't like to be known as Ronald. He was R.A. Fisher. 1925, he published Statistical Methods for Research Workers and then introduced hypothesis testing and p-values. He produced tables for specially selected values of p, but there was no particular emphasis on 0.05. And his sort of attitude was, when p is between 0.02 and 0.05, the result must be judged significant, but barely so. The data do not demonstrate this point, or presumably a treatment difference, beyond reasonable doubt. The way I put it is p less than 0.05 is not strong evidence. It's a start. P less than 0.001 is strong evidence, and then you begin to use phrases like proof beyond reasonable doubt. So there we are. That's how he began. There's the man himself, the founder of statistical inference, working on the latest technology of computing in 1925, a mechanical calculator. That's all they had. Then all was going along well with the p-value until along came Neyman and Pearson in the 1930s. And they produced a hypothesis testing formulation saying the null hypothesis versus the alternative hypothesis. If p is less than 0.05, you reject the null hypothesis. If p is above 0.05, you accept the null hypothesis. Fisher said, I don't like this. The calculation is absurdly academic. No scientific worker has a fixed level of significance at which he rejects hypotheses. So he says, this is not the way to think. I say, he's right. It's not the way to think. All your statistics courses, I bet you were taught that way. Accept, reject. And it's junk. Throw it out the window. The p-value is like this. It's about the smaller the p-value, the stronger the evidence. I call it shades of grey for those who've watched pornographic films and such like. I do anything to get your attention, you see. P-values are about shades of grey. You start at 1 with pure white, no evidence of difference, and then it gradually gets darker, stronger evidence against the null hypothesis. The p-value gets smaller. The other thing to say is a p-value is no substitute for a brain, and think whether you've really got a treatment that matters. Don't believe the p-value. So that's a start in that direction. Sorry, a little soreness in my throat, so I'll just take a drink. Now, I'm going to take swipes at a couple of things that happen. First, beware of big effects in small trials. There remains a controversy on whether perioperative beta blockers are of use in non-cardiac surgery. There was a trial called Decrease with one of the beta blockers, bisoprolol, published in the New England Journal nearly 10 years ago. Nearly 20 years ago, sorry. And it's bisoprolol versus control, and they showed these differences: fewer deaths and no myocardial infarctions. You had to feel this was too good to be true, and it was, because there was actually subsequently claims of scientific misconduct for this trial, and therefore it's now withdrawn from the New England Journal as not trustworthy. Now, you can have this kind of result in other trials that were done correctly, and you can have luck, but you're still allowed to say this is too good to be true. This cannot be the real effects of a drug. It doesn't make any sense. And indeed, the POISE trial of metoprolol was then done, much bigger, huge trial. Myocardial infarction, yes, less MIs, but more deaths. So what could be worse? And so metoprolol at this dose clearly was doing potential harm. And therefore, the ESC and ESA guidelines a few years ago have to say the evidence is inconclusive. And what we now need is more trials in this area, different doses of different drugs, to see if a beta blocker really has any evidence of efficacy. And this trial was an example of a big trial, of a small trial, big effect gone wrong. So now let me turn it round and say beware of small effects in big trials, turning the whole thing round. The Improve It trial was 18,000 patients with an acute coronary syndrome who were all still taking a statin, simvastatin, and they were randomized to ezetimibe versus placebo. Now, the composite primary endpoint, and you get a lot of these composite primary endpoints in cardiovascular trials, because you know you'll never have enough deaths to really show an effect for death, and therefore you combine other non-fatal events into a composite, a very common thing in my world. This was a composite CV death, MI, stroke, unstable angina, coronary revascularization. And this trial was huge, and they were going on, and they planned to go until 5,314 patients had a primary event. It shows how huge these trials are over a mean 5 years or more follow-up. This was effectively the definitive study of ezetimibe. And screw up your eyes, and you can see there is a little difference here on the Kaplan-Meier plot over 7 years, but it is small. Of course, if you believe in p-values, you're all right, because the p-value is 0.016. And if you believe in p less than 0.05 is magic, you're even more all right. But I hope I've already dismissed that idea and saying there's modest evidence that the treatment may be efficacious. The hazard ratio is 0.936, which means on a relative scale, a 6.4% reduction in risk. But what matters is to look on an absolute scale as well, and you can see there's a 2% difference in the Kaplan-Meier plots out to 7 years. And the number needed to treat is therefore 50 patients need to be treated for 7 years to prevent one event. That's not a lot. That's not a lot of efficacy. So there's a modest treatment reduction, modest impact on cardiovascular primary events. And is this a worthwhile benefit? I believe the FDA didn't think so, and therefore ezetimibe in this context, it didn't really make it. So let's enter the more modern world, the exciting results this year of the Odyssey outcomes trials. They have lovely names, Odyssey this time. alirocumab is a PCSK9 inhibitor that is already known to have dramatic reductions in LDL cholesterol. It's down by 60%, which is way above what is achieved with statins. And they did this very large trial in patients with acute coronary syndromes, 19,000 of them. And they had only a modestly elevated LDL cholesterol. Some would say this was quite normal these days. And they were already on a high-dose statin. So the versus placebo, and again, you have a very similar composite primary endpoint, which this time I won't read out. And they were followed up for 2.8 years. So what's going on? Does it really work? Well, the simple answer is yes. This is the Kaplan-Meier plot. The divergence is a little bigger than what we were seeing in the Improve It trial. And the hazard ratio is now 0.85, meaning a 15% reduction of risk on a relative scale. And the p-value is now a healthy 0.0003. So I think you take this as proof beyond reasonable doubt that we have treatment efficacy in this context. It's interesting to note two things about Kaplan-Meier plots. You notice when do they diverge, and there's no evidence of any efficacy in the first year of treatment, which is important to note. So you're in the long haul. There's no point in putting a patient on these drugs for a short while. And secondly, never trust a Kaplan-Meier plot to the end. And this is an example where you can see the number of patients at risk are falling away. Less than a half have been followed for 3 years, and less than 10% have been followed out for 4 years. So the real body of evidence is out to 3 years, and this is just a bit of fun added on the end, if you like, shouldn't be trusted too much. So that's another thing about Kaplan-Meier plots. Now, the primary endpoint is a mixture of things. So you want to look at that mix of components of the primary endpoint. When you have a composite, next step is look at the details. And you can see in this occasion that of the details, coronary heart disease death, which you'd fairly say is the most important outcome, trending in the right direction, but not a significant result. It was for myocardial infarction and stroke, and a little bit for unstable angina, that we saw the benefits. So you're not really reducing cardiac mortality, you are reducing the risk of non-fatal events. The next thing is don't get obsessed with the hazard ratio or the relative risk reduction. 0.85 means a 15% risk reduction. You need to look at the absolute reduction in time to the first MACE, as it's often called, major adverse cardiovascular events rate. And here you can see the absolute risk reduction is 5.62 events are prevented per 1,000 patient years of treatment. And secondly, put a confidence interval around it to express the uncertainty. And in fact, the number of events prevented per 1,000 patient years of treatment might range plausibly from about 2.3 up to 8.9. So even though you've done a huge trial, very positive, there's considerable uncertainty still about what the magnitude of effect is. We like to convert that commonly into a number needed to treat, and you can do that with various calculations. What I've done here is you need to treat 63 patients for a median of 2.8 years to prevent one event. But this is often done, number needed to treat, without putting the uncertainty around it. And in fact, we can see it's actually, the 63 has a range from 41 up to 141 confidence interval for what this number really is. Notice this confidence interval for a number needed to treat is not symmetric. It's being the way the calculation is done. And as I've already said, no apparent benefit in the first 12 months. So far, okay, that's the details for the primary endpoint. Now they want to make claims on secondary endpoints. How do you do that? Usually we have a hierarchy of testing, whereby if you pass the primary endpoint, you are predefined an ordered sequence of secondary endpoints which you want to test, and you can go one to the next one, you work your way down until you hit what you might call a failure. So CHD event, major CHD event, cardiovascular event, death, MI, and stroke, all tick the boxes, all highly significant. Then you hit CHD death, and it's not significant. That's the end of the secondary claims sequence. But they'd like to go on. Cardiovascular death, equally, didn't quite make it. In the right direction, but not significant. But if you then do the calculation for all-cause death, you get a significant result, a P of 0.026. But you didn't get there in the hierarchical testing, so this little tick has to go in brackets, meaning that's interesting, but it's declared to be an exploratory finding rather than a major result. The fact that you had to get a result for all-cause death with non-significant findings for cardiovascular death and non-cardiovascular death is a little strange. So I think there's a little doubt about whether this is a real phenomenon for all-cause death. Equally, the other trial, the Fourier trial of evolocumab, analogous drug. In fact, some people are inclined to think they're the same drug disguised in different ways. There's no mortality signal in that trial, casting doubt on this claim. Now, you thought that would be the end of the story, but no. At a conference presentation, remember, the author is allowed, the presenter, like me, is allowed to say what they want, and therefore there's no peer review, and therefore they wanted to try a little harder, and therefore they went into subgroup claims. And they wanted to claim that alirocumab is more effective in patients who start with a higher LDL cholesterol. 24% reduction in the primary outcome, MACE, and a 29% reduction in death. Cheating, positive spin. Because when you look at those with a high cholesterol versus those with a lower cholesterol, there's no significant statistical interaction between the treatment effects in the two subgroups. Interaction p-values of 0.09 and 0.12. So it's suggestive but not convincing that these are real phenomena of extra benefit. So this is what I would call an example of, you have a positive trial and then you add a little positive spin on top, just because you want to. More plausible, I think, is that the absolute benefit for MACE is greater in high-risk patients. And I think what you should do in a trial like this is stratify patients from low risk to high risk, not just on their LDL cholesterol, but on the whole profile of the patient. And it's probably the higher risk patients, older perhaps, have more cardiac history, who you will find will have the greater absolute benefit. And we are awaiting those results, which I hope will happen. So the general issues arising from this trial, which I'm spending some time on, is firstly, it's important to estimate the magnitude of any treatment effect on a relative reduction scale, such as a hazard ratio, but also you need to quantify the uncertainty around it. Equally important is go to an absolute risk reduction scale, what's the absolute benefit, and put a confidence interval around that, either as a difference in percentages or as a number needed to treat. And as I've already said, the absolute risk reduction I would expect to be greater in high-risk patients. So I could pause, ask any questions at this moment. I just need to pause anyway, I thought. I don't have to get to the end of my lecture. I'd rather you joined in. But if you're reticent because it's not Spanish style, I'll understand. But, any questions at this point? Oh, dear, dear, dear me. You're just like teaching statisticians in London. Never mind. Let's go on. That's all right. I'm sorry to tease you. The next trial, there's nothing like a trial heading that is the meaning of life. That sounds like it really matters. This was a trial called LIFE, an acronym LIFE, which stands for something. I'm sure the L is losartan. Because it was a trial of a sartan versus atenolol, a large trial, 9,000 patients with hypertension, high-risk hypertensive patients. And the primary endpoint was the typical one for a hypertension trial, which is death, myocardial infarction, or stroke, and they followed patients over 4.8 years. You can see they had fewer primary events in the losartan group, 508 versus 588 in the atenolol group, and therefore the relative risk reduction was 13%, with a modest p-value of 0.021. The publication in The Lancet said losartan prevents more cardiovascular events than atenolol, but steady on. That's a bit of an over-positive claim, because it's not overwhelming evidence. If you do a trial in 9,000 patients for 5 years and you only reach a p-value of 0.02, you should not be getting excited about this result. Also, what about the absolute risk reduction? Well, let's do that. The absolute risk reduction in the LIFE trial was there was a difference of 4.1 events per 1,000 patient years of treatment, with a confidence interval from 1 to 7 events. So huge uncertainty. If you put that on the number needed to treat, you get 244 patient years of treatment are required to prevent one event, using losartan rather than atenolol, and the 95% confidence interval is very wide. So it's a small gain, imprecisely estimated. Stop getting excited, one might say. What happened with the regulatory context is we were a bit conned by this primary endpoint, and I don't have a slide on it, but all the action was in stroke. And so in the end, they got an indication for stroke, not for the composite, which illustrates my point again. Look at the details of any composite, don't just lost in the overall summary. So my next slide is warming up on subgroup analyses and the need to interpret with caution. I don't mean don't do them, but don't necessarily believe them. Patients are not homogeneous, so there's a response to treatment may well vary across treatment subgroups, and therefore it's legitimate to explore this issue. But trials are not large enough usually to tackle this sensibly. They are powered for an overall result, so you lack statistical power to detect subgroup effects. But that won't stop you doing it, you'll do it anyway. But the next thing is there are many possible subgroups and you need to guard against data dredging and coming up with false positives when you make a claim in a subgroup, like we just saw in the Odyssey trial. And do not rely on subgroup p-values. You need to use interaction tests instead, which I'll explain on the next slide, because I haven't let go of life yet, so to speak. A second life study was reported on the diabetic subgroup in the same issue of The Lancet, actually. And their claim was that the benefits of losartan were more marked in this diabetic subgroup. And the results looked like this. For diabetics, who were the minority, they are at high risk. So diabetics will have more cardiovascular events, and we know that, but that's not really the point. And you saw that in both diabetics and non-diabetics, there were fewer events on losartan versus atenolol. This relative risk of 0.77 is significant for the diabetics. This relative risk of 0.89 is not statistically significant for non-diabetics. Don't be misled by what I just said. What you need to do is say, is the relative risk in diabetics significantly different from the relative risk in the non-diabetics? Is there evidence that 0.77 is really convincingly smaller than 0.89? And the answer is no. The p-value for interaction, or the test for heterogeneity, is 0.22. That's what's needed in deciding whether a subgroup claim has any real meaning. So there's insufficient evidence that the drug is actually more effective in diabetic patients. The problem with this publication is it only gave the diabetic result, and this one didn't even appear if you read the publication. Always when you study a subgroup, you need to look at the contrast, the others as well. So I'm really having a go at the Lancet today. Never mind. I have good friends in the Lancet. Well, I did have good friends in the Lancet. Oh, here's another one. Oh, dearie me. Here we go. Can we be more sensibly cautious in subgroup claims? This is another complicated acronym. It's called the Current OASIS 7 trial. And the drug clopidogrel, the antiplatelet drug, you needed to know on the background of aspirin whether to give standard or double dose clopidogrel. Was the double dose going to be more efficacious? And it was a huge trial, 25,000 patients with acute coronary syndrome. Early September 2010, if you open the New England Journal, you read the following. In patients referred for an invasive strategy, that is, they're going to have a PCI, you think, there was no significant difference between double dose and standard dose. So you go away saying, oh, no benefit of double dose. You open the Lancet on the same day, and it says, in patients undergoing PCI, double dose was associated with a reduction of cardiovascular events. Are you confused? Yes. Why did the confusion happen? Firstly, you could argue the authors got greedy and they wanted simultaneous publications in two journals. Well, that's aiming quite high, but Salim Yusuf is a very persuasive man, if you've ever met him. So Current OASIS 7, the primary composite endpoint was cardiovascular death, myocardial infarction, and stroke. Overall, this is the New England Journal finding. The incidence of those events over 30 days, no evidence of a difference. So clearly, that's it. No, try harder. Subgroup analysis, we divide patients up into those who went on to have a PCI, percutaneous coronary intervention, and those who did not, those who continued on medical therapy. And you can see for those who went on to have PCI, which was the majority, you did get a hazard ratio of 0.85 and a significant treatment difference. Now, for those who did not get a PCI, you see it's actually going in the opposite direction, but not significantly so. The hazard ratio is now above 1. If you do what I say you should do, you compare those two hazard ratios, and actually the interaction test is also significant. So they felt they had some justification for making this claim. But beware. Going on to have PCI is an improper subgroup. Improper in the sense, at the time of randomization, making the decision which dose to give, you didn't know whether they were going to get PCI or not. So if you like, bluntly, it's an invalid analysis, because you can only really do subgroups on things that are known at the moment of treatment choice. Things that happen later are not relevant, really. Qualitative interactions, things going opposite directions, are rare and implausible, and so this secondary evidence is weak. But that's how it happened. So that's subgroups. Occasionally they really matter. Mostly they lead you astray. Oops, sorry, am I clicking in the right place? Now, strategies for handling secondary endpoints. Predefine a limited set of key secondary endpoints, and others not on that list become exploratory. You can predefine either as a hierarchy of secondary testing, like that was done in the Odyssey trial I showed you earlier, or you can do corrections for multiple testing, such as Bonferroni correction, multiplying by the p-value by the number of tests done. Strict control of type 1 error by avoiding false positives, if it's good or bad. It matters to the FDA and the EMA because they are responsible for making clinical regulatory decisions. So they need to control type 1 error to avoid false positive claims leading to approval of new drugs. But it's less appealing for scientific knowledge and for publication of results in a medical journal. And I think there should be, in the medical literature, there should be a little relaxation of the formal control of type 1 error when coming to conclusions. And what I like to think of it is you need to have a little flexibility without actually having blatant cheating. The next thing is all-cause death different? Does that overcome all these fusses? Because it's the ultimate outcome, isn't it, all-cause death? Happens to us all. And so is that on a different plane of thinking? So I'll give you two examples in the diabetes world for cardiovascular outcomes trials, because one drug, I've forgotten its name, oh dear, Avandia, got taken off for apparent cardiovascular harm. Every drug now in diabetes, as you probably know, has to undergo a very large safety trial to rule out an excess of cardiovascular events on their drug. I'm going to talk about a safety concern of heart failure in the SAVOR trial, and an apparent efficacy bonus of mortality reduction in the EMPEREG trial. My prior statistical perspective on surprises of secondary endpoint is any unexpected finding, good or bad, is prone to be an exaggeration of the truth. Secondly, you need to note there are multiple hypotheses across multiple secondary endpoints. If you collect more data, if you can, you'll probably get a regression to the truth. You'll get a more modest finding as you get more data. And is it a real effect in a secondary endpoint or just due to chance? It's often impossible to tell, and I'll give you an example. Now, so far, I've only discussed positive findings. Here, I'm now going to present a safety concern. The SAVOR TIMI-53 trial was saxagliptin, which is in widespread use, versus placebo in 16,000 or so high-risk type 2 diabetics. These trials are huge. 788 sites in 26 countries, followed for a median of 2 years. And you have to remember, It's done as a non-inferiority trial to show saxagliptin is as good as placebo. Has the world gone mad? You do wonder sometimes. But this madness does reveal a little concern. The primary endpoint, CV death, MI and stroke, revealed no difference really, a hazard ratio bang on 1. And because you could claim non-inferiority, which was the purpose of the trial, because the non-inferiority margin was set at 1.3, and the upper limit of the confidence interval here is 1.12. So you're safely under that. So if you only believe in primary endpoints, you'd go away saying here, saxagliptin's okay for cardiovascular safety. But you look at one of several secondary endpoints, heart failure hospitalization, and you see a significant excess on saxagliptin. A surprise, a nasty surprise. Hazard ratio of 1.27 with a p-value of 0.007. So it looks plausible enough to be bothered about. But the heart failure issue is, given multiple testing, is this a false positive or is it a real issue? Well, the 2 other trials were done of the same class of drugs, alogliptin, sitagliptin, and the excess of heart failure events on the SAVOR trial out here was not backed up by either of the other trials. Examine alogliptin's slight excess, but nowhere near significant, and the larger TCOS trial, bang on no effect. Depends which meta-analysis method you use, fixed effect or random effect, as whether you get an overall significant finding. But there's no formal evidence of heterogeneity between the 3 drugs. So what do? What does the regulator do? Do you therefore ban saxagliptin as causing an excess of heart failure events? No, I think you perhaps add a cautionary note to the labeling saying this finding was there. But we really don't know to this day whether it's a real phenomenon or a chance finding. I would go for a chance finding personally, but I don't make decisions. I just talk a lot. Now let's go to the good news. EMPA-REG outcome trial. Empagliflozin was studied in 2 doses versus placebo and in 7,000 type 2 diabetic patients. The usual primary endpoint, CV death, MI and stroke over a median 3 years. And at least they had good news at last of a drug that seems to reduce cardiovascular risk. When you looked at the combined endpoint of CV death, MI and stroke, you had a marginally significant result in favor of the active drug, p-value of 0.04. But amongst secondary endpoints, not necessarily planned in advance as of importance, you found a reduction in heart failure hospitalizations and a remarkable reduction in all-cause death, 5.7% versus 8.3%. And the p-value for all-cause death is p less than 0.0001. So how do we interpret such impressive secondary findings, particularly all-cause death? Do we believe it or do we not believe it? And when you get to the FDA advisory panel, do they approve that indication for reducing all-cause death or not? Well, first, I took something very rare for me. I became a Bayesian statistician for about 5 minutes in front of the FDA panel. So this was my little bit of meaningful fun, I think. We said, here's the evidence on a scale here of the efficacy. Hazard ratio of 0.68, a reduction in risk. And when you're looking at the likelihood, the distribution around that efficacy, you can do this blue curve. Do you believe it, or is it too good to be true? Well, the way you can tackle that as a Bayesian is say, what was my prior belief regarding the impact of empagliflozin on mortality? Well, my prior belief, to be truth, was skeptical. You would say, I don't think it's going to do any good or any harm. But it's just possible it might do a little bit of good. It's also possible it might do a little bit of harm. So you create this prior distribution of what you think was plausible to expect for empagliflozin on mortality. Then you apply Bayes' theorem. You combine the prior skepticism with the data to say, what should I now believe? And that's called the posterior belief distribution. And that's calculated using Bayes' theorem, and you get the following result. You get still, you think, plausibly a 24% reduction in mortality with a fairly tight confidence interval. I presented this result to the FDA panel, and other arguments were put forward that this was a real phenomenon. How did the panel vote? Did they vote in favor of approving or not? Well, what did they do? They voted 12-11 in favor of this approval of the indication for reduction in all-cause mortality. And hence the FDA went on to approve that. Who voted yes, who voted no? It turns out that the cardiologists and the statisticians voted yes, approve. The endocrinologists are a cautious lot and they said, no, this cannot be true. And they did not vote. Interesting. There we are. That's my wonder of being a Bayesian. I'm not normally. But if the trial had been much smaller, then you would have not overruled the prior skepticism, and your posterior belief would have be fairly near to where you started. So it's only because the evidence is so strong that you overcome prior skepticism. I think it's an interesting concept. You don't have to necessarily do formal calculations, but it's an interesting other way of looking at results. Right. The Compass trial was a trial that stopped early, so I'll talk about that. It was 27,000 patients with stable cardiovascular disease. Two dose, there was rivaroxaban at a low dose plus aspirin, but also rivaroxaban at a higher dose alone, and then low-dose aspirin as the third arm. The primary outcome was death, myocardial infarction, and stroke, and the trial stopped early for superiority of the combination, which from now on I call R plus A for short. And the median follow-up was 23 months. So what were the results that led to the stopping? What they showed was these were the number of primary outcome events. And you can see that the most were in the aspirin alone arm, somewhat less in the rivaroxaban alone arm, and a lot less in the combination arm, which is what the fuss was all about. And if you compare aspirin alone versus the combination, you get a very healthy p-value of 0.001. And this seems to hold up pretty well for the subcomponents of the primary. But it's not a free ride here. Rivaroxaban is an anticoagulant. Added to an antiplatelet, you're going to get more bleeding. And there was a gross excess of major bleeding at a similar p-value, p of less than 0.001. So strong evidence of efficacy, strong evidence of a safety concern regarding bleeding. So it's not a trivial matter to say it's a winner. Because if you look at the difference, you prevented 117 primary outcomes and you caused 118 major bleeds. Some people would call that a draw. But it depends whether you think the primary outcomes are more important than the major bleeds, which is open to debate. There were formal stopping rules, but I think I'll keep going and skip those. So the issues re-stopping a trial early for a major efficacy indication. It means that you have an extreme stopping rule, which means the superiority on the efficacy outcome is believable, but it may be exaggerated somewhat because you're more likely to stop a trial on a random high, being a bit lucky, than you are to stop on a random low, being a bit unlucky. So there's an inbuilt bias towards trials that stop early, exaggerating the truth. The mean follow-up was therefore restricted to 23 months, which is meant to be a long-term treatment, so there's less assurance on the long-term benefit, and you've got less data to trade off as regarding efficacy versus safety. And the regulatory consequences of all this are still taking place, I believe, with the FDA and EMA. So my message, stopping for efficacy, beware of this potential to be exaggerating the truth. Can a negative trial be rescued? Sometimes yes, sometimes no. Firstly, I'm playing into the p less than 0.05 failure here. Ularitide in acute heart failure, and there's a lack of treatments in acute heart failure that do work. And they had two primary endpoints, cardiovascular death and a clinical composite. Nothing showed any difference, seemingly a totally negative trial, but it was a sloppy trial in the sense that 16.6% of patients shouldn't have been randomized. They were ineligible. And also there was missing data on some. So when you do a little bit of special pleading, you say, let's only look at the eligible patients. then you see a little trend of more improvements in the clinical composite outcome over 48 hours and a p-value of 0.035. A weak signal of short-term benefit in eligible patients. This requires cautious interpretation, and I wouldn't think it would sway the balance of approving such a drug. It might possibly lead to more research. But this is an indication of concerns about quality of trial conduct in this particular case. Let's look at another one. In heart failure again, international variations. Were some countries deficient in their trial conduct? This seems to have happened in a trial called TopCat, which is spironolactone, an old drug approved long ago, versus placebo, but not approved in preserved ejection fraction heart failure. The primary outcome was cardiovascular death, cardiac arrest, or heart failure, and the hazard ratio was 0.89. Not significant. Then you look at the international variations, and this particular trial, half the patients came from Russia and Georgia, and there were few events and they appeared not representative. Whereas in the rest of the patients in the Americas, including some from Latin America, the hazard ratio is 0.82 and you seem to have a significant treatment benefit. You can see what it was like. This is the Kaplan-Meier plots for Russia and Georgia and for the Americas. What is going on in Russia and Georgia in what they recruited? Were they ineligible patients who didn't really have a heart failure? Or were they patients who, or they were inadequate in their follow-up, so they failed to detect events? But this is another issue of trial conduct. Now, Christina, I think I will skip the next few slides and go to my conclusions. I was going to take a dig at meta-analysis. Don't trust them, unless it's mine, of course. I had an experience of meta-analysis in treatment of flu, and to be blunt, I was entering a dirty world scientifically, because I was deemed to be collaborating with a drug company. Oh my God, what's the matter with me? Roche did all the trials. There was evidence of efficacy, but we found that using such a drug by such a meta-analysis, you could alleviate symptoms by about a day, 25 hours. You got better a day earlier. On the way, you wouldn't feel too good because of the risk of increased nausea and vomiting. But I found I was in a world where there were people who knew the answer that Tamiflu was no good. And they'd do anything to denigrate anyone who said it might be good. And so this was a dirty world that I've left. I don't wish to collaborate in flu. I've gone back to the lovely, clean world of cardiology. Actually, if you believe that, I'm lying. But anyway, there we are. My conclusions. Clinical trial reports cannot be automatically trusted, and constructive clinical appraisal is always required. Positive spin, what I like to call being economical with the truth, is common. Trialists and sponsors struggle with attention. The search for truth, honest science, versus the desire for a positive trial. And that's the conflict every investigator faces. Journal articles are more reliable than conference presentations, but they only take you so far, and only regulators get anywhere near to the full story of what's really going on. So I'll conclude there. There's a bit of further reading. Not only do I talk too much, I also write too much, and there's a collection of references in recent times on similar themes. Thanks for listening. I hope I entertained you. Thank you.